Lamellar keratoplasty is a surgical technique of partial transplantation of donor tissue after the dissection of the diseased host cornea. The history of lamellar keratoplasty goes back to over 100 years. The first successful lamellar keratoplasty was done by Arthur von Hippel at the end of the 19th century. It is well known that problems with the host endothelium are a leading cause of graft failure with penetrating keratoplasty. The most obvious advantages are it is an extraocular procedure that spares the host endothelium, thus avoiding needless complications. In spite of these advantages, lamellar keratoplasty has not been popular because of its perceived technical difficulty and interlamellar haze. Here, we demonstrate a surgery of limbal dermoid excision with lamellar patch graft to highlight the technique. Limbal dermoids are benign congenital tumors that contain choristomatous tissue or tissue that is not found normally at that site. The limbal dermoids appear most frequently at the inferotemporal quadrant of the corneal limbus. Visual morbidity may result from encroachment of the lesion into the visual axis, development of astigmatism. A detailed preoperative evaluation included gonioscopy and ultrasound biomicroscopy. A conjunctival peritomy surrounding the conjunctival side of the lesion was performed with Vannas scissors. The smallest trephine that would completely surround the lesion was chosen and used to make a partial thickness cut. The vertical edge of the dissection was kept perpendicular to facilitate donor tissue placement. A 350 micron guarded blade was used for perpendicular dissection. A lamellar dissection was performed, beginning on the corneal side of the lesion and carried across the limbus into the sclera. Globe perforation is an infrequent but hazardous complication. Adequate caution was taken to avoid any perforation of the globe. A lamellar dissector was used to maintain a single plane of dissection within the cornea. The donor material consisted of a corneoscleral button up to 3 mm scleral rim. This tissue was mounted on an artificial anterior chamber. The intrachamber pressure was checked before dissection of the donor button, maintaining the intrachamber by closing the valve or applying the clamps provided with the unit. A 350 micron guarded blade was used for the initial incision and a stromal pocket was made with a crescent blade. The depth of the pocket was extended over the entire cornea all the way to the limbus 360 degrees using straight and curved dissectors. The donor tissue was then placed endothelial side up on a punched refined block. The diameter was measured and an extra 0.25 mm was included, and this oversized tissue was punched. In this case, the donor tissue was optically good and had a good quality. We used a posterior disc for endothelial keratoplasty on a different patient. The donor tissue was sewn into the recipient bed with interrupted sutures. Post-operatively, the patient received topical steroid and antibiotics. The sutures were removed approximately 3 to 4 months after surgery. Lamellar keratoplasty not only ensures gratifying results but is also a safe and effective procedure. We have seen no loss of visual acuity in any of our patients of limbal dermoid treated with excision and lamellar keratoplasty, which is truly gratifying.